All right. Welcome back, everyone. Again, my name is Harrison Steins. Thank you for joining this installment of Critical Care Echocardiography, especially as it relates to the wilderness and austere settings. So, in the previous section, we did an intro into critical care echocardiography, kind of what the overall exam looks like, and we focused on the parasternal long axis view. This next section is going to be about measurements, so estimating the ejection fraction and cardiac output. And this is important because quantitative assessments like fractional shortening, which we'll go over, fractional area change, and cardiac output add objectivity to visual impressions of left ventricular function. So something that we're going to walk through is EPSS, endpoint septal separation, and it's a quick surrogate measure for left ventricular systolic function when image quality is poor. And these metrics are crucial when determining whether hypotension is due to a pump failure, distributive shock, or preload depletion. So if clinical signs are ambiguous, you can use some of these tools to help aid your clinical picture. So we are going to convert qualitative impressions into numbers. That's useful for serial monitoring or a consultation, say, of a cardiologist or an outside team if you're in an austere setting using telemedicine. In some of our patients, our applications are sepsis, trauma, and when we're measuring cardiac output or endpoint septal separation, this may help guide our determination as to whether we're using fluids, how much fluid we're going to bolus someone with, and whether or not we use inotropes when our physical exam is equivocal. And as far as utility goes, these can be obtained with minimal image optimization, which is ideal for combat or chaotic environments, such as where we might have a portable ultrasound, but not necessarily one with full cardiac capabilities. It's going to calculate things such as VTI for us. So from this parasternal long axis view of the left ventricle, I've put up a couple of scene clips. And these scene clips are our way of doing a quick qualitative approach to estimating ejection fraction. So this is the quick and dirty way of eyeballing, is this patient in severe heart failure, HFrEF, HFpEF, or do they have hyperdynamic heart function? And hyperdynamic heart function, seen up in the top left corner up here, is mostly due to decreased preload, right? So you have cases of hypovolemia, catecholamine surges, underlying conditions like hypertension, sepsis, or changes in cardiac function reduce that preload, needing the heart to work faster. So we're visually assessing the basal and mid-ventricular and septal portions, right? We're observing how well the walls are pulling in from the left ventricle. Are the walls pulling in evenly from the external part of the left ventricle to the interventricular septum? Are they pulling in too much, not enough? And then we're observing the mitral valve. How well are the valve cusps co-opting, and how well are they slapping against the interventricular septum and the septal wall? So in normal ejection fraction, 55 to 69, 70%, we can see that the mitral valve leaflets are co-opting well together. Obviously, we don't have color Doppler over, so we can't see if there is some sort of regurgitation. But we're also seeing that they're slapping against the interventricular septum and the septal wall very well. We're looking at the ventricular wall motion. So at the interventricular septum and the ventricular wall, they're coming together well in systole and pushing out well in diastole. Same thing with the bit of the right ventricle that we can see there. We're also looking to see that there is no stasis of one part of the wall. The walls are moving symmetrically and all together. As we move on to mildly reduced ejection fraction and moderately reduced ejection fraction, I think this is a good example where we can see that the cusps of the mitral valve don't seem to be slapping as vigorously, for lack of a better term. And then we're also seeing reduced contraction of that right ventricle, and we can't see all of the left ventricle, but it looks like there is some reduced contraction of the left ventricle, both at the ventricular wall and interventricular septum. And finally, going on to a severe ejection, severely reduced ejection fraction, under 30%. There's almost no movement outwardly of those mitral valves, so to come closer to that interventricular septum, which I think is an easier way to see it than at the ventricular wall. And it almost looks like fibrillation. It's not quite, the left ventricle's trying to move closer and together on systole, but you can see that there's almost no movement. So there's almost no ejection of blood out of the left ventricular outflow tract to the aorta. So we can see here. Same with the right ventricle here. So this interventricular septum's pretty static, and there's no movement inwardly of that ventricular wall. So we've taken our eyeball measurement. We've seen if the heart is hyperdynamic, if it's moving very, very quickly. We've seen if there is reduced ejection fraction qualitatively. We've looked at the mitral valve slapping. We've looked at the movement of both ventricles in proportionately and symmetrically with vigor or without. But now we want a qualitative measurement of ejection fraction. And so we can use a couple of different options. So we can use fractional shortening, fractional area change, or endpoint septal separation, and those are what I'll talk about. There's a couple other methods, but those are the three that I'm highlighting. I think something we'll talk about, endpoint septal separation, is the easiest to find, and probably on a point-of-care bedside ultrasound, that's the one I'm using the most. But looking at fractal shortening or fractional shortening, it's the proportional difference between a linear dimension of the left ventricle in systole and diastole. So right under the first sentence is an equation that we'll be using. In reality, the ultrasound machine is going to be using it when we take these two measurements with our calipers. This is the equation that it's going to be putting those two measurements in to find the fractional shortening. So we have fractional shortening is equal to the left ventricular internal diastolic diameter minus the left ventricular internal systolic diameter divided by left ventricular internal diastolic diameter times 100. So how we're going to find this view is we're going to be in the peristernal long axis view, selecting M mode and placing the cursor in the middle of the left ventricle, being careful not to include the mitral valve or the papillary muscle. We're going to be freezing this in an M mode image, so M for motion, looking at the motion capture under the ultrasound transducer where things are moving, and then measuring the left ventricular end diastolic diameter and the left ventricular end systolic diameter. And you can think about this just as if you have a container and you want to see how much is actually in the container after you squeeze it, like a water bottle, you're going to measure the amount of volume or the space taken up by that container before you've squeezed it, and then after you've squeezed it. And that'll show you how much you've actually squeezed out. In the same way that measuring how big the heart is at the end of diastole and then how much smaller it gets at the end of systole can tell us how much fluid has actually moved out of that heart. So that'll give you an ejection fraction reading. Once you put it into the ultrasound machine, it should give you that same thing. But we have this equation here so that we could do it on our own. So in that peristernal long axis view, lining up in the center of the left ventricle, making sure not to include those leaflets or the muscles at the inferior aspect of that heart, taking a motion capture or motion mode scene clip, and then taking your calipers and putting it onto that ventricle at the end of diastole and end of systole. So in a male, a normal ejection fraction would be about 25 to 43% change or fractional shortening of that diameter or that area that you've taken. And here's a chart with some descriptions of normal and abnormal. So the next way that we can estimate ejection fraction is pretty similar. So instead of taking shortening of two walls, we're going to take the overall area change of the left ventricle. So I think that this image here on the right has a very intuitive way of thinking about changing the area volume and measuring the size of that container, the left ventricle, while it's being filled and then while it's squeezing out. So we compare the area of the left ventricle when viewing the mitral valve function in the peristernal short axis view during systole and diastole. So, right, we'll be changing to peristernal short axis for this, looking at a cross section of that left ventricle. We'll be at the level of the papillary muscles, taking a measurement at the end of diastole, which will be the maximum area of fluid, the end of filling, and then comparing that to the end of systole, the minimum area of fluid, of fluid inside the left ventricle. And then we're inserting these values into the equation, which is over here on the right, to obtain the fractional change. So I think this one's a bit harder, just because as opposed to having a defined image of where that interventricular septum and the ventricular wall are stopping, you are needing to look at a peristernal short axis view and not fully aware of how high or how low you should be going in terms of diameter. That's at least my take. Obviously, someone who's much more experienced with ultrasound could probably find it in both. But there are limitations in that if you do have regional wall motion dysfunctions, so think about like a prior MI where you have had ischemia to one part of the heart, and that heart has a regional wall motion abnormality, it's not going to be moving as well as the other parts of the heart, and that may result in over or underestimation of global function. So for the same reason, I tend to use the EPSS or the fractional shortening if I needed to, but mostly EPSS, just because you don't necessarily know about the regional wall motion abnormalities that may exist there. Again, here's a estimation of ejection fraction based on the fractional area change. So next we'll look at probably my most used method of estimating left ventricular ejection fraction, which is the endpoint septal separation. So the endpoint septal separation is the distance between the anterior leaflet of the mitral valve and the septum, called the EPSS, which we can see right here. So it's taken when the mitral valve has reached the maximum excursion during early diastolic filling. So during diastolic filling, we want the valve to be fully open. And this value is worse if the EPSS distance is larger. So essentially what that's saying is the mitral valve isn't making its way all the way to the interventricular septum. In a heart with reduced ejection fraction, as we were seeing on that quick eyeballing method for estimating left ventricular ejection fraction, the mitral valve wasn't slapping against the interventricular septum if you have an ejection fraction of, say, like 30 or 40. So how do we take this? The most crucial step in obtaining is getting a good peristernal long axis view. You want to really be able to see both of those mitral valve leaflets and a horizontally oriented left ventricle. You place the M-mode cursor over the tip of the mitral valve as the anterior leaflets travel toward the left ventricular septum, and once you've captured that in a scene clip, then you can turn on M mode and measure the distance between the mitral valve, the E wave, right here, and the A wave, which is the mitral valve in systole. So that symbolizes the left atrium passive filling of the left ventricle, and then active closure. So here we have measurements of estimations of left ventricular ejection fraction from the endpoint septal separation. We're using this formula 75.5 minus 2.5 times the EPSS. According to cardiac MRI data, EPSS measurements less than 8 millimeters are considered to have a normal left ventricular ejection fraction, while measurements 8 to 18 are mild to moderately reduced ejection fraction, and then over 18 is severely reduced ejection fraction. So after the EPSS is obtained, we can put it into this formula to calculate the left ventricular ejection fraction, or you could do it on your own. There's a couple of apps out there that have this formula in them. I really like this. I believe it's from POCUS 101. Just having all of these calculations lets you do it if you're in a resource-limited place where you only have a single transducer that is not hooked up to a machine with any cardiac settings. You can just use M mode, calculate those with just a caliper, and then put them into this calculation to come up with an estimation of your left ventricular ejection fraction. There are some limitations there, things that are affecting only the mitral valve, like calcifications or repair, can't then let you estimate a global cardiac function or global function of the left ventricle because that mitral valve has a problem with it. So here we have a YouTube link. I think it'd be awesome if you guys are watching this to go check out from POCUS 101. It's just an EPSS example running through step by step on an actual ultrasound machine. So if you pull this up next to your ultrasound and your patient while you're doing it, maybe not your patient, maybe someone you're practicing with, and then go into your patient, it's a great way to get those physical correlations with what you're actually doing and the material that you're learning here. Okay, so we're going to be looking at the cardiac output calculation. So you'll notice a lot of these images are really, really beautiful. They're coming from POCUS 101, which is a great resource for anything ultrasound. I used it for a lot of the material in this presentation, as well as just for a lot of my own learning throughout medical school. So thinking about cardiac output, as everyone knows, it's the basically just the amount of blood pumped by the heart in a minute, and it's how we get blood to flow around the body. So essentially the volumetric flow of the heart's pumping output, that is the volume of blood being pumped by a single ventricle of the heart per unit time. And we can use ultrasound to come up with an estimation of the cardiac output, and it just involves estimating the amount of blood, the stroke volume, that comes out of left ventricle at the left ventricular outflow tract. And we take two measurements. POCUS 101 has an awesome calculator if your ultrasound device doesn't have cardiac calculations built in when you're using your caliper to measure things. It's linked in my PowerPoint presentation, but you can just Google POCUS 101 cardiac output stroke volume calculator and you'll find it. We're going to go through the actual kind of math behind it, which is pretty basic, but bring back the idea of integrals, which for many people in medicine we haven't thought of in a long time. So we use two measurements, the left ventricular outflow tract area, and then a velocity time integral. So essentially how fast something is moving under a certain or in a certain amount of time, and that's where an integral comes into play. So you're looking at time under under a curve. So if you think of the left ventricular outflow tract as a cylinder, which is illustrated in this nice image right here, we're measuring the amount of fluid coming out of that left ventricle over a certain amount of time to estimate the stroke volume. Once we get all of these measurements, then we can put it into this equation, which I think is a super handy pocket card. So this is our cylinder. So pi r squared sounds like area to me. The rhyme doesn't work as well with a cylinder, but essentially it's pi times diameter over 2, which would be the radius squared, times your height. For stroke volume calculations, we're going to use the same concept, the idea of area in a cylinder and then movement of a fluid under a graph of time. So we're taking the left ventricular outflow tract diameter, seen on the bottom here, and then plotting it against the velocity time integral. And then you can simply calculate it based on the formula. So going through these calculations in a stepwise fashion, I really like to have that cardiac output card from POCUS 101 next to me while I'm doing this. If I'm doing it on, say, like my B-scan that doesn't have the calculations or cardiac mode with me, or I'm doing it on another tool that doesn't. So first thing we're going to do is identify the peristral long axis view of the left ventricular outflow tract. We've already been here. We've taken a bunch of these measurements already. So we're freezing the screen, then we're measuring the left ventricular outflow tract 0.5 to 1 centimeter from the valve orifice, which you already knew, and measuring at mid-systole. So if you're not using a machine with the function, then you can put that measurement into this equation that we have down here, and that's also on that card. Once we've done that, we're going to flip from a peristral long axis view looking at the LVOT to a apical 5 chamber view. And in understanding the apical 5 chamber, we want to know that we can see the left ventricle, right ventricle, obviously right and left atria, and then that aorta. And that aorta is where we're actually going to be taking this measurement from. So we've identified the left ventricular outflow tract and the aortic valve. This is a beautiful apical 5 chamber view. We're going to take our pulse wave Doppler, which is going to show us a visual representation of the flow under that transducer, and then ensure that the gates are parallel and place that pulse wave Doppler gate at the aortic annulus, so the base of the aortic leaflets, and you can see that right here. So we can see these aortic leaflets opening up right here in this 5 chamber view, and that's where we want to position our pulse wave Doppler gates. Once you've placed your pulse wave Doppler gates, then we're going to be identifying the velocity time integral. So going back to calculus, whenever you took it, integral, right, is area under the curve. So we're going to be using the pulse wave Doppler to take an image of the amount of fluid moving under the transducer under a certain period of time. So we've identified our landmarks with the gate in place. We're activating the pulse wave Doppler. Then you're going to freeze and calculate the LVOT velocity time integral. What we mean by that is here's our tracing from our pulse wave Doppler. This creates our curve, the outline in yellow, and then the area under the curve, tracking our velocity time integral, is this area within that yellow outline tracing. So a normal left ventricular outflow tract velocity time integral is around 20 centimeters. So that's calculated by assuming a normal stroke volume is 60 milliliters and an average left ventricular outflow tract diameter is 2 centimeters. And if you use the cylinder formula to calculate that, a normal LVOT comes out to just about 20 centimeters. So once we've gotten left ventricular outflow area and the stroke volume, we can put them into the last step, step 3 of our stepwise process to actually get the cardiac output. Your machine might be doing this for you, but fortunately we have our little pocket card with all of these calculations on them so that we can do them ourselves.